Myocardial infarction. So what is myocardial infarction? So when people say heart attack, in your mind, what is happening to the heart? Right, so a heart attack, myocardial infarction, is caused by what? Let's start there. Right. Yeah. So blockage of a coronary artery does what? Prevent blood from sending oxygen and glucose to what? The heart muscle cells. So therefore the heart muscle cells can't do their job, which is what? Contracting. Right? So if the heart muscle cells don't contract, the chambers don't contract, there's no pumping action. So in essence, that is what's happening with the heart. It interrupts the heart's ability to pump blood effectively. So some heart attacks are worse than others. And what does that depend on? Which part? Right. Which part of the coronary circulation is blocked, and what part of the heart is supplied by that those particular arteries. Okay. So now let's get into some of the normal action of the heart. So we know the heart contracts, the heart beats, but this next section I wanted to say for the beginning of lecture. So this has to do with how the heart knows when to beat. What tells the heart muscle cells when to contract? And before we get into that, I wanted to point out these two properties of the heart. So one is the myocytes. What again is myo? Muscle. And what is cyte? Cell. So they're usually called myocardial cells or cardiac myocytes, the heart muscle cells. So they have a very important job, right? All of our cells have important jobs, but when you think in terms of how important the heart is to life, then it is these cells that is actually doing the job. So the heart is said to be myogenic. And what that means, in genesis, origin, is kind of what you think there, is that the heart beat actually originates in the muscle cells themselves. So the heart is myogenic because it can naturally contract and relax and doesn't need to receive impulses from a nerve to make it contract. So that's different from the other muscles that we've learned about, right? Our skeletal muscles don't contract unless what happens? What has to happen before our skeletal muscles contract? The brain has to send a signal, right? So a signal has to come from the CNS and be sent out to that muscle. Otherwise, that muscle just stays relaxed. And the example of that is if a person has an accident that damages their spinal cord, they're paralyzed because there's no signal from the brain getting out to those muscles. The heart muscle cells are different. They can cause contraction without the aid of the central nervous system. Okay? So that's why we say the heart is myogenic. The cells can have their own action potentials basically and cause the muscle to contract. So the heart is myogenic, not neurogenic. That's what that means. So myogenic just means the stimulus occurs in the heart muscle cells themselves and not by stimulation of a neuron. The heart is also autorhythmic. Okay, what does that mean? So autorhythmic means that the heart sets its own heart rate, own rhythm. So cells of the SA node, which we'll get into, the sinoatrial node, initiate action potentials at a constant rate. So we've talked about action potentials in neurons. Well, also the heart cells, the myocytes, have their own action potentials, kind of like our skeletal muscles have action potentials. And then there are other parts of the heart that are not muscle cells, but they're nodal cells. And that's what we're going to take a look at now. So the cardiac conduction system is the part of the heart that is not the muscles, but it's the part of the heart that stimulates the muscle cells externally. Okay, so these parts of the heart are called the nodes, and they generate signals, and I kind of think of them as, they kind of behave as neurons, but they are not part of the nervous system. They're part of the heart, but they kind of send signals as neurons would. So the nodes, as they are SA node, the sinoatrial node, which is known as the pacemaker. And then there's an AV node. What does this word mean? Atrioventricular.
That's the tricuspid and bicuspid valves.
So the tricuspid and bicuspid valves are atrioventricular, but why are they called atrioventricular?
Because they're between the atrium and ventricle.
Their location. They're between the atrium and ventricle. So the AV node is between the atrium and ventricles. Excuse me. And then there are specialized fibers, again, that are not muscles, but they are going to be part of the conduction systems. And they are called the atrioventricular bundle, or bundle of His, and the Purkinje fibers. So let's look at those in this figure and see if it makes sense to you. So the SA node is here, sinoatrial node in the atrium, and there you have the AV node. Okay, then you have the bundle branches, and Purkinje fibers. So just think of those as acting or serving a purpose similar to what neurons do. So the SA node fires. And then when the SA node fires, that sends an electrical impulse to all the muscle cells of the left and right atrium. Okay? So when the SA node fires, an electrical stimulation is sent to the myocytes of the left atrium and the myocytes of the right atrium. And what that does is tells those muscles to contract. Okay? Now, what we said before is that the muscle cells don't need to be told when to contract. They can contract on their own. Right? Remember that? That's because the heart is myogenic. So why is there a need for the SA node? So the SA node is going to tell them to contract together. Okay? So the muscle cells themselves have the ability to contract, but they don't contract in unison. So what good is it? The heart is not able to pump forcefully unless they all what? Contract together. So that's the job of the SA node, to tell all the atrial cells, okay, it's time to contract now. And then that causes what? Contraction of the atria, and that causes the blood to be pushed down into the ventricles. Okay, so that's the SA node. So the SA node is directly responsible for contraction of the atria. Keep that in mind. When it fires, sends a signal to the atrial muscles. The atrial muscles have action potentials, and then they contract. And at the same time, the SA node fires, it also sends a signal to that other node, which is the AV node. So when the AV node gets the signal, it fires, and then that signal or impulse is going to travel down the AV bundle, the bundle branches. And notice what they're connected to, the Purkinje fibers. And the Purkinje fibers stimulate the ventricle or ventricular myocytes. Okay? And that causes them to contract. Now, think about that for a moment. So when you hear your heartbeat lubbed up, again, the sound is coming from closure of valves, but it correlates to the contraction of the atria and the ventricles. So whoever designed the heart, why wouldn't they have wanted the SA node to stimulate the atria and ventricles at the same time? There's kind of a lag. So first you have the contraction of the atria, then the atria relax, and then you have contraction of the ventricles. Why do you think that's important? Why not just contract the whole heart? Exactly. So it would be impossible for the blood to flow in one direction. It would be kind of like if you have a water balloon and just squeeze it in the middle and let it go. There's really no one-way flow of the blood in that sense. So the way the heart is designed is for the atria, they say no, to tell the atria to contract. They contract and relax. When they contract, what's happening to blood? It's going through the AV valves and into the what? Ventricle. So you really want to wait for the ventricles to fill before the ventricles contract, right? Does that make sense? So this takes a fraction of a second. Once the SA node gets the signal to the AV node, now the AV node has to get the signal down these bundle branches into the ventricles before the ventricles start to contract. So that gives the ventricles time to fill up. And notice another thing. So when the ventricles contract, all of the ventricular myocytes don't contract together. The ventricle myocytes at the apex contract first, and it's kind of a wave-like motion for the ventricles. So it's like the bottom of the heart contracts first, and then that pushes the blood upward. It would make sense for the top of the ventricle to contract first, right? Because what would happen there? That would be pushing the blood down to the apex, but you want whatever's in the apex to be pushed up through either the pulmonary valve or the what? Or the aortic valve. Okay? So that is the conduction system, cardiac conduction system. So the SA node directly stimulates contraction of the atrium, the left and right atria, and the AV node stimulates contraction indirectly of the ventricular myocytes. So those are the components there. So the contraction, so this is the left and right sides of the heart working together in what's called the cardiac cycle, or one heartbeat. So you have systole, which just means contraction or active phase, and diastole is relaxation. So you should have an idea when the atria are in systole, what the ventricles are doing at that time, and when the ventricles are in systole, what the atria are doing at that time. So you have systole of the atria, then diastole of the atria, then systole of the ventricles, and diastole of the ventricles. Okay? So, so here we're looking at an electrocardiogram, ECG or EKG. And what this is a composite of all action potentials and nodal myocardial cells, amplified and recorded by electrodes in the arms and legs. So again, the myocardial cells and the nodal cells have action potentials. So their electrical impulses are amplified, recorded. And that's what you see here in the ECG. So for the test, I'll have a picture, something like this, and you should be able to identify what those parts are. So this first hump is called the P wave. And then the spike in the center is called the QRS complex. And then you have the last hump is the T wave. Okay, so you should be able to identify those in a picture. And not only that, you should be able to tell me what's happening with the heart during each of those periods. And that information is here. So during a P wave, what is happening? The SA node fires. What do we say happens when the SA node fires? It stimulates, it sends a signal, electrical signal to the atrial myocytes. Those muscle cells have action potentials. They depolarize, then they have action potentials, and that causes contraction, atrial contraction or atrial systole. Okay? So SA node fires, atria depolarize, just like in an action potential you have depolarization, and then that causes the muscle to contract. And that contraction is atrial systole. Begins about 100 milliseconds after the SA signal comes in. The QRS complex, the spike in the center, that is, during that process, you have the ventricles depolarizing, and the complex shape of spike is due to the different thicknesses of the shape of the two ventricles. And shortly, so ventricular depolarization precedes contraction. So during the ST segment, what is that? We don't really get into all that's happening there. But when you all get into the nursing program, you'll know what the heart is doing at each of those points. So between S and T, the end of the QRS complex and before the T wave begins, that is where you have contraction of the ventricles. Okay? So that's called the ST segments. Ventricular systole, plateau, and myocardial action potential. So if you look in the book, I don't really ask you about the specifics of the action potentials of the heart, but the action potentials of the heart include calcium. Nervous system, you had sodium and potassium, but calcium is also included when we talk about action potentials of the heart. And the calcium causes a plateau. So it's not a spike action potential like that. It goes up and then kind of plateaus and then comes back down. And that's because of the presence of calcium there. So the T wave is where you have the ventricles repolarizing and then going back to their relaxed state. All right, so this slide kind of helps to coordinate the actions of the heart with what you see going on in the ECG. So this may help you to kind of put those things together. Okay. Yeah.
I have a quick question. You may have already alluded to this, but it's kind of...
Yeah.
I have a quick question. You may have already alluded to this, but it's kind of bugging me. What keeps, as the signal travels down the interventricular septum, what keeps the superior portion of the ventricle from contracting before the apex,
yeah, good question. Very good question. So again, that has to do with the bundle and the bundle branches. Those themselves are not stimulating. There's no stimulation of the ventricles at that point. The stimulation of the ventricles come when the signal gets to the Purkinje fibers, which you can see in here.
So it doesn't actually stimulate the ventricles until it hits the Purkinje fibers?
Exactly.
Okay.
Right. Okay, so there are branches coming off of the bundles going to the Purkinje fibers, but it doesn't occur until you get to the apex and then comes back up that way. Good question. Okay, so what can an EKG or ECG tell you? It can tell you about any abnormalities in the conduction pathway. So what are we talking about when you see conduction pathway? what we just looked at. So if a person has a heart attack, for example, and they survive it, what if the damage is in this part of the septum? That's going to have an effect on the conduction system getting the signal to the appropriate part of the heart. So if there is any damage to the conduction system, then that would show up in the ECG. Also, some people need a pacemaker, right? An artificial pacemaker. Why would they need an artificial pacemaker? Because their SA node is not functioning properly. So that's also has to do with the conduction system not functioning properly. Okay. And we'll look at some of the effects of that in just a second. Myocardial infarction, we just talked about that. So myocardial infarction can show up in ECGs. Nodal damage to the nodes, SA node, AV node, heart enlargement, and electrical and hormonal imbalances. So all of those can be observed or be identified in viewing someone's ECG. So up here, the first picture you have is the ECG of a normal patient. So that's called the sinus rhythm, the normal rhythm of the heart. You would have a normal ECG. And notice the one below. What's different about it? The P wave is missing, right? So you all notice that? So there's no P wave. So what's the issue then? There you go. So we know what normally happens if there is an SA node firing. There's going to be a P wave. So if there's no P wave, that tells you the SA node is not firing. Okay? So the nodal rhythm, and there are a couple of points so make sure you know the differences between the nodal rhythm and the sinus rhythm is normal, right? So sinus rhythm. And there you have a normal ECG, and the heart rate. Anybody know the normal heart rate, resting heart rate for an adult at rest? Good. So the heart rate is between 60 to 100 beats per minute. So that's normal. If a person has a nodal rhythm, that means their SA node is not firing. And the result of that is going to be the heart rate is going to be between 40 to 60 beats per minute. Beats per minute. So that's, again, an adult at rest. Okay? So if your heart is beating 40 to 60 beats per minute, usually that's not quite enough. So you get tired very quickly. And then there is something called an intrinsic ventricular rhythm. And that's when neither the AV or SA or AV nodes are firing. Okay, and then under these conditions, the heart rate is even lower. It's between 20 to 40 beats per minute. So obviously, a person whose heart rate is only 40 beats per minute is probably just lying in bed and having a difficult time just getting up to use the restroom. So that will require the aid of artificial pacemaker. And then there's something called fibrillation. Fibrillation. And that is when there is no pumping activity of the heart. This person is out cold, passed out. And without quick aid, they will expire quickly. So fibrillation, what happens there is there's no AV node activity for a period of time, and then the heart muscle cells just start doing their own thing. Like we said, the muscle cells, the heart is myogenic. The muscle cells can contract on their own. They can generate their own action potentials, but nothing is telling them to contract at the same time. So the heart is just kind of wiggling because the individual muscle cells are just kind of contracting at their own pace. And that means that there's not much of a force to pump blood from one chamber to the next or out of the heart. Okay? So keep those in mind. So, since we're on heart rate, so normal heart rate, 60 to 100. And what is it called when heart rate is above 100? I think someone said it the other day. Heart rate above 100 versus below. Very good. Below 60. So tachy, can I spell today? Tachycardia versus bradycardia. All right, so start thinking about some question types I can ask. So I can ask a question like, a person's heart rate is 45 beats per minute. Which of the following would be an explanation? Or which of the following, So, and then I would ask you something like, if the person's heart rate is 55 beats per minute and they have no P wave, that would result in, that would mean they would have a what? A nodal rhythm. Okay. And I could also have, so that could be A, nodal rhythm, B could be intrinsic ventricular rhythm, C could be tachycardia, D could be bradycardia, and then E could be two of the above, or A and C are correct. So if a person is experiencing a nodal rhythm, is that also an example of tachycardia or bradycardia? So that's also bradycardia. So I usually have questions like that where you have to pick out more than one, right? So so just remember, bradycardia is whenever the resting heart rate is below 60. Tachycardia is whenever it's above 100 beats per minute. All right, cardiac cycle. So the cardiac cycle is one complete contraction and relaxation of all four chambers of the heart. Atrial systole, we just went over this a moment ago, when the atria contract, the ventricles are in relaxation. Okay, so you're not going to have the atria and ventricles contracting simultaneously. And then the quiescent period is when all four chambers are relaxed at the same time. In a resting person, atrial systole lasts about 1/10 of a second, ventricular systole 3/10 of a second, and the quiescent period 4/10 of a second. So the total duration of the cardiac cycle is about 8/10 of a second in a heart that is beating at 75 beats per minute. Okay, a couple of terms here. End diastolic volume. So these terms will be on the exam. So during diastole, so try to start thinking now about when the chambers are contracting, where would you expect to find the maximum amount of blood? And that's kind of what we're talking about, getting ready to get into here. So during diastole, the ventricles can expand. One other thing. So notice here, it doesn't tell you which chamber we're talking about. So if you just see diastole by itself, it says during diastole. It doesn't say during atrial diastole or ventricular diastole. So most of the time in the textbook, if you don't see one of the atria or ventricles, you are to assume it's referring to the ventricles. Okay? The ventricles are where everything happens basically, because when the ventricles contract, that's when blood is being sent out to the body. Okay, so during diastole, ventricular diastole, you would expect the ventricles to expand, right? Why? Huh? Because they're filling up with blood, right? So whenever the ventricles are relaxed, what's happening is blood is flowing down from what? The atrium. So the ventricles are going to expand. Okay, the pressure drops below that of the atria. The AV valves open. So remember, the AV valves have to open in order for blood to come into the ventricles. So end diastolic volume is just what it looks like. It's the volume of blood in the ventricle at the end of ventricular diastole. Think that through. So end diastolic blood volume. So volume is referring to what? The amount of blood that's in the ventricle at the end of ventricular relaxation. So if you're at the end of ventricular relaxation, what's going to happen in the next moment? Contraction. So there's another way of saying this. End diastolic volume is the amount of blood in the ventricles just before the ventricles what? Contract. Okay? The amount of blood in the ventricles just before the ventricles contract. So that will be the maximum amount of blood that you could get in the ventricles. Because in the next second, it's going to start pushing that blood out. Okay? The amount of blood contained in the ventricles at the end of ventricular filling or just before ventricular contraction. And for an adult at rest, that amount should be 130 milliliters of blood in each ventricle. Okay, so now, what happens when the ventricles contract? Blood is ejected from the heart. Where does that blood go? Either into the pulmonary trunk or the aorta. Okay? So, the stroke volume is the amount of blood ejected by the ventricles. Okay, so when the ventricles contract, the amount of blood that is ejected is called the stroke volume. Okay, so here it says, so we started with 130 milliliters of blood in the ventricles before it contracted. After contraction, the amount ejected was 70 milliliters. So how much is left? after ventricular contraction? 60 milliliters. So that 60 milliliters is referred to as what? The end systolic volume. So at the end of contraction, okay? In systolic end of contraction, you have 60 milliliters of blood remaining in the ventricles. Okay? So when you're at rest, your ventricles are only pumping almost a little bit more than half of the blood that's in the ventricles. So the ejection fraction is 54% when you're sitting here at rest. Whereas when you're exercising, that can go as high as 90%, because when you're exercising, not only does your heart rate speed up, but the contraction gets stronger. So more blood is going to be forced out per contraction during exercise. Okay, so this is just an overview of what we just saw. So how much blood is in the ventricles at any given time here. In systolic volume, you have 60 milliliters in the ventricles. Passively added to the ventricles during atria, so when the atria are resting, blood is just naturally flowing down into the ventricles. How much? About 30 milliliters. And then when the atria contract, an additional 40 milliliters is sent into the ventricles. And that's how you end up with 130 just before the ventricles contract. Okay? And then when the ventricles contract, you have blood being forced out of the ventricles. That is your stroke volume. And how much is ejected? 70 milliliters. So that means 60 remains. And note this last statement at the bottom here. Both ventricles, what? Must eject the same amount of blood. So the two ventricles have to maintain the same amount of blood. Otherwise, you get a backup. And that's, I think we mentioned this the other day. And that can lead to heart failure. So think about this. I want you all to not only just look at the picture, but kind of have an understanding of why. So if the right ventricles, think what's happening with the right ventricles. The right ventricles are sending blood where? To the lungs, right? So if your right ventricles are sending out more blood than the left ventricles. So basically that's saying the left ventricles, so the right ventricle is sending blood to the lungs, but when that blood gets to the left ventricle, it's not going to pump out as much. So where does that extra stay? The extra blood is going to stay where? In the lungs. Okay, so that results in pulmonary edema. So that's something else that can happen after heart attack. If the heart attack affected a small part of the left ventricle, right, you need all of those ventricle muscles to pump out that 70 milliliters of blood. So if all of your muscles are not contracting, all of that blood is not going to be ejected. So some of the blood ends up staying back in the lungs, and that is what causes pulmonary edema. And that eventually will lead to failure, left ventricular heart failure, because it's not pumping out an adequate amount of blood. The balance can be on the other side too. So if the left ventricle's output exceeds the right, the left side of the heart is sending blood where? To all of our tissues. If the right side is not pumping adequately, then the fluid has to stay back in the body tissues. So that leads to systemic edema, which could result in swelling, feet swelling, leg swelling, and swelling in other parts of the body. And congestive heart failure results from the failure of either ventricles to eject blood effectively. So that's heart failure. Okay, so usually due to a heart weakened by myocardial infarction, as we talked about, chronic hypertension, So hypertension that goes on for years and years without being properly treated. Valvular insufficiencies, congenital defects to the structure of the heart. Okay? So those are just some of the effects there. And cardiac output is the amount of blood ejected by ventricles in 1 minute. So you can compare cardiac output to stroke volume, right? So what do we say stroke volume is? The amount of blood ejected from the ventricles every time the ventricles contract. Okay? So that's stroke volume. Cardiac output is the amount of blood ejected from the ventricles in 1 minute. So we're including time in this one. So that means you have to include stroke volume and heart rate. So cardiac output equals heart rate times stroke volume. Okay, that should make sense to you. So our cardiac output is about 4 to 6 liters per minute for a resting adult. Also, a red blood cell leaving the left ventricle will arrive back at the left ventricle in about 1 minute. And with vigorous exercise, again, everything increases, heart rate increases, but also stroke volume increases. So that means cardiac output can increase from 4 to 6 liters per minute to 21 or even 35 liters per minute for a world-class athlete like myself. Just joking. All right, heart rate. So we mentioned these: tachycardia, bradycardia, normal heart rate. Infants have a heart rate of 120 beats per minute. And heart rate rises again in the elderly. Tachycardia, we mentioned bradycardia. So stress, anxiety, drugs, heart disease, fever can all cause the heart rate to increase above normal. And also loss of blood or damage to myocardium. So loss of blood, the autonomic nervous system can detect that, and what it detects is the drop in pressure if you're losing blood, and it tells the heart to speed up in order to increase pressure. Okay, bradycardia occurs in sleep, low body temperature, and endurance trained athletes. So some athletes have a naturally lower heart rate. All right. Okie dokie, I think